highly privileged and honored to be part of this panel discussion as a moderator. And there are very few occasions when you have all that pure tech guys on a panel discussions. It's like, most of us are CIOs of one or more hospitals. I remember that movie, Karthik Calling Karthik. So it's like CIO calling CIO. Uh, so let's enjoy this. But for me personally, it's an adrenaline moment, to hear from such a focus group whose wisdom and actions are observed by the industry. So let's cherish this, discussion. Uh, we said that AI is going to be one topic, and prior to this, in the previous panel, AI, was rightly mentioned as an augmentation to physicians, clinicians, radiologists, and so on and so forth. I think whole world is talking about AI. While humans are struggling to have some common sense, we all practitioners, be it policymakers, even politicians are talking about AI. And AI is already in place with respect to fintech, education, and fraud detection to large extent in most of the other industry. So my first question to you, Sunil, is that, what is the context of AI in healthcare and more so in India?
Thank you, Rajiv. Uh, I think I am from government side, so let me talk what we have experienced in public health, because my experience comes from there. So about 2-3 years back, government of Karnataka contacted NIC to find out a solution to a problem where they say there is a shortage of what we call radiologists in Karnataka. So we have radiologists at district level, and we have machines like digital X-ray machines and other digital machines in CSC or PSC, but radiologists are not available. So we have come up with a product called eCollab DDS, which is a teleradiological solution. So the CSC and PSC, they upload the basically X-rays and other and they are uploaded, and diagnostic the reports are prepared by the radiologist at the district level or at the state level. So last year they approached about 10,000 such cases were evaluated using this software. Now last year they approached us, and they requested us to create one AI solution, so that the diagnostic are done by the AI solution. So two kinds of requests they made. One is basically there are 11 diseases which are in the chest X-ray, so which are diagnostic through chest X-ray. So basically, out of these 10,000 images, we have 8,000 images which are related to chest. So we tried to develop one model, AI model, and use these 8,000 chest X-rays for developing the training of that model. And based on that, we have successfully come up with the AI model, and now they are being used to basically evaluate the AI is applied, and the diagnostic are done on the basis of that model. And similarly, we have a 30,000 X-rays, real X-rays related to TB from ICMR. And another model for TB was also, so these two models have basically helped us in identifying the TB in a faster mode and identifying the image, the 11 diseases in the chest using the another model. So this way we have find out, we have 5 level processes. One is basically we need one front-end application. Second, we should have basic data for developing the model, like training of the model. And third thing is basically anonymized data for that. And the fourth is basically if there is a gap between the doctor's report and the this report, AI report, then retraining of the model is to be done. So this way, this AI, and apart from this, we have come up with other models also, which are coming up, and they are being used in public health sector. So this way, AI in a public health has helped us in diagnosing, and this radiologist shortage of radiologists has been attended in the government of Karnataka. Now we are replicating this model across the country.
Great, Sunilji. Great. I think we all know that country as a whole has a serious shortage of doctors, and especially when you took an example of TB, I think more number of people died because of TB and this remains undetected. So fantastic example, Sunilji. Now, Vishal, my next question to you is that Sunil mentioned about couple of examples, and there are no dearth of examples which are there in AI as far as the healthcare is concerned. So why it is taking so much of time for practitioners to adopt AI in healthcare?
Thanks, Rajiv. So as Sunilji mentioned, Rajiv, so there is no doubt that AI can do wonders. There is no doubt in terms of the capabilities of AI in healthcare domain. So be it predictive analysis, be it decision support system, reducing cost, improving quality, reducing workload. There are so many use cases or I should say the proven use cases of AI into healthcare. So now the question is why there are so many challenges. So I think, Rajiv, the answer is lies in the definition itself. Because if we see the Oxford Dictionary that says the AI is the system that makes systems able to perform the tasks where generally the human intelligence and the human intervention is required. So that creates a kind of a perception, and that perception I see is the biggest challenge in the healthcare professionals. So if my system is able to perform the task which needs my degree or which needs my intervention, then why am I required? So that perception is the major challenge. So we need to understand that AI is the technology which is going to augment the healthcare professionals, not to replace them. So that perception has to be corrected. The second challenge is the data, which we call the EMR data. So as we know that AI is the technology which is kind of an analysis of the data and making intelligence out of that. So if we do not have a meaningful EMR data, or if we do not have the good amount of adoption of the EMR data, then we are not going to use the good AI adoption in the country. And unfortunately, Rajiv, India as a country is still on a very poor numbers in terms of the EMR adoption. And I should say that there are very few hospitals in India, like yours, where the EMR adoption is good, but most of the hospitals are still struggling in terms of EMR data. So we need to have a meaningful EMR data. And the third thing is, even if we have the EMR data, we need to ensure that that EMR data is a structured data. Because most of the EMR data which we are generating in India, the first challenge is that data is generated outside India, so that is not very relevant. It is not helping really us in terms of the AI perspective. The second problem is the data is coming as unstructured data. So I was a part of the ABDM implementation. I was leading that for India. So the one initiative where we started is, let's talk about the unstructured and let's convert that unstructured to the structured data so that we have the meaningful EMR. And that EMR we can use in form of the EHR for the AI purpose, let's say. So there are lots of profiles which are available from the EBDM portfolio with the help of CDAC. There are lots of FIRE profile per se. And then I think there is a good initiative already done in that. So that was the third challenge. The fourth challenge is the AI, the tools, the services which are developed outside India, most of the successful tools. And their architecture is not kind of a very interoperable with the Indian scenarios, so I should say. And that's why the integration of these AI application with our corporate, or I should say the legacy HIS application, EMR application is difficult. So the doctors face really challenge to use those AI tools in our corporate hospitals, let's say public hospitals. And the last one is the privacy of the data which is there in the AI tools. So I think India is already on the right place. There is a strong, digital consent framework. There is a strong health information exchange framework. So that is already resolved. So I think these are the major challenges which is stopping AI to have a great adoption. Though all acknowledge the use, they all acknowledge the capabilities, but still due to n number of these reasons, I think there is a less adoption.
Yeah, very rightly said, Vishal. Thank you. So, Praveen, my next question is to you. Vishal mentioned about what are the possible challenges, and some of these challenges are there in almost each and every industry in one flavor or the other. But when you talk about healthcare, there is a concept of zero tolerance. You can't afford to have in a fintech, if a loan is not given to someone because algo was wrong, it's still manageable. But in health tech, a wrong diagnosis, and previous panel was very clear on the diagnosis part. So what, according to you, are the major risks which are there in adoption of AI in the healthcare sector in India?
Sure. So I totally agree that, yeah, healthcare is one sector where we cannot afford any misdiagnosis, right? So, and we all are aware, especially from the tech industry, folks, that any tool, any software could potentially have a bug or an error. And that can definitely be the first deterrent, especially when it comes to healthcare, because we cannot afford to have any misdiagnosis. Secondly, like we just talked here, AI on its own will not be able to treat a patient. It will be more like assisting another human. It could be a doctor, it could be a clinician. So R is human. We all have heard of this. So there are cases where, end of the day, finally, we are all human using a tool, and we can also make, mistakes. So whether it's a missed diagnosis or a misdiagnosis. So either way, we might have a patient having a real concern, and we using AI might say, oh, based on the data set or based on the tool that we have, he is not suffering from ailment, or vice versa. He may not have an ailment, but based on the AI tool we are using, we could be classifying him as a higher diagnosis. So that is one common and very important. On top of it, of course, we talked about the data privacy part of it. Unless and until we have very strong guidelines, policies around it, it can potentially have impact on the data privacy protection and security of it. Another point that I would like to emphasize here is, since all the AI tools are based on a data set, right? They start using a current data set, and then you use that to kind of extrapolate and predict for a futuristic patient in this case. So if the data is not properly normalized, it can have a bias built in the data. So it could be bias based on the gender, based on the age, based on socioeconomic strata, or race, ethnicity, because we all agree that most of the current AI tools are something that are pretty much based on some of the Western data sets and not necessarily Indian data set. We are beginning to do that. And one of the challenge for that would be standardization. We may not have a good enough data in a standardized format to be able to even used in a setting that we are all in. So all that definitely adds up to the complexity and the risk of it. And one last point is the accountability. Suppose we use AI and there is some mishap. Who is really accountable for it? So there are no firm guidelines around it. So that also puts together a risk in its own.
Great. Thanks, Praveen. I think you mentioned a couple of points, and let me add one to that, because when we were also doing one such project, we introduced the traceability. We were having a log of each and every action, and during the blind study, when we realized that there is not a dispute, there is a difference between a radiologist and the algorithm, we were able to figure it out why the algorithm gave that particular result based on those traceability points. And either the radiologist was right or wrong, we were able to correct that algorithm. So, my next query to you, Sushil, sorry, Dr. Sushil, you represent All India Institute of Medical Science, which is one of the most respected and established organization in the country. Lot of times, when someone wants to visit a doctor, especially in Vedanta, he says, is he from X aims? So that's the reputation you carry. With respect to AI, my question to you is that uh, there are so many risks or challenges which are there, both in practitioner mind as well as for public in general. What, according to you, government should do, to promote AI, whether to come out with a policy or a framework, and what, according to you, should be the major ingredient of this policy?
Yeah, it is one of the toughest question for me. Yeah. Already my panel members, they have already spoken about the standards. Where is the standard has started? Because government was not serious about digitization of healthcare in 90s. First, seriously, the project has started, this telemedicine project in 1999. And they have started in 5 locations: AIMS, PGI Chandigarh, Sanjay Gandhi Lucknow, Jipmer, and Apollo. And they found that we do not have any standards. That's why you can't standardize the medical record. Then they have set up a committee by the Ministry of IT, MIT, and that is 2005. And they developed one standards. But that standard was not sufficient because people do not visualize that what kind of digital record it's supposed to be. Then they have formed seriously the committee has formed in 2009, and 2012 the EMR standard, National EMR standard has come up. But when it has asked for the implementation, still that is not sufficient. Then what they have done it, they have formed another committee to make another standard that is called MDDS, metadata and data set. Then it has given a look that, okay, the patient will come to a primary health care, then he has to come to a secondary health care, then tertiary care, what records supposed to be, and how it will visualize. And each records, whatever the medical information is storing, it has to be a standard and uniform and universally acceptable. And it's supposed to be meaningful. Because if you go in the south, let's take some medicine is prescribed in Delhi. If you go to the south, the nomenclature has changed. And you will not find that kind of medicine there. Or from the south, in north also you will not find it. This kind of things, still it is there. But right now, many things it has come up with the standards. In 2016, again EMR standard has been again modified. With some of the points they have added it, the security, confidentiality, and how to make the logs and all these things. But everything is in place, but how to use it? People are not ready to accept it. Most of the hospitals, they are not ready to accept it. Because in the private sector, the cost is the most important because when you do the whole system in digitizations, the cost is very high. And they have to comply with the ROI, so it is a challenge for them. In government, they do not have vision that much for other hospital. In my institute, there is not an issue, but in other institutions, there is a lot of problems that why they will go for digitizations, because they do not have that type of infrastructure and manpower. So that's why government has thought, let us have another committee, and that is another ecosystem, and it has made up, that is the ABDM, Ayushman Bharat Digital Mission. They have thought, wherever the digital record is there, let be there, but it will be accessible to the patients where they have registered. That's why they have already been to the public digital health ID. It is already been in the public domains. You can make your digital health ID with authentication of your Aadhaar ID. But in summarizing me, when EMR record is there your record is standardized. Let's take your personal identification, it will come through the Aadhaar. Your demographic details, it will come to your Aadhaar. Your lab reports, it will be standardized with the LOING. Your imaging, it will be standardized with the DICOM standards. Your many things, it is there, it is already been compliance with the international standard. So if this record, it will be placed in one place, it can be shareable and it will be meaningful. So that's why ABDM has come up and it is playing a major role, and a great extent it is successful. And during the COVID times, it has been used maximum way because of vaccinations. And people have started, they are thinking of it, they need a single medical record in the country. So those who do not have done any health ID, you can do it. It's a free of cost. You go to the COVID websites, here it is also available. You can go for it. Thank you.
Thanks, Dr. Sushil. I think you said it very, very right, that I think country is moving in that direction, especially with ADM coming into picture. I just want to ask organizer, is our time out or do we have 15 more minutes? 10 minutes. Great. Now you will realize that why tech is not adopted in a hospital, because tech is the only, department which is given neither the resources nor the time. So now coming back, to you, Sunil, you have been attached with ABDM, and Dr. Sushil mentioned about ABDM. What according to, and we are talking about 75 years of independent, Azadi Ka Mahotsav. For 75 years, I think forefathers thought about two important policies, education and healthcare. And my personal belief is that both of them are in serious mess, serious mess. So what, according to you, suddenly this connected hospital, smart hospital, ABDM is going to do healthcare for India?
Okay, thank you. I think in last two sessions, we have been hearing one important word, that is integration. So information integration cannot happen until unless we have certain standard in place and some common key is available. So I think for that, government has set up this Ayushman Bharat Digital Health Mission. So primarily it has 5 components. One is basically ABA ID, as has been mentioned by Sushil also. So ABA is Ayushman Bharat Digital Health Account. So it's an account, it's not ID. So we should know the difference between that. And the second is basically HFID, Health Facility ID, given to every health facility of this country, and that is unique. So that will, and another is professional ID, that is given to the doctors and other health professionals. And the fourth one is basically consent management. So government consider that whatever health record is being created, that belongs to, the ownership belongs to the patient. So patient has to give the consent for sharing the electronic data. So for that, consent management system has been put in place. And the fifth building block of this ABDM is UHI, Unified Health Interface, which is coming up in some of the applications. Very soon you will have in PHR apps. So let me tell you how these 5 building blocks of ABDM, Ayushman Bharat Digital Health Mission, building blocks, they have been put into use by various applications across the country. So I come from NIC, so there is a product called e-hospital. So it's a HMIS solution, and in that HMIS solution, we have RCH, reproductive and child health, we have CGHS. These are all IT applications are there. So all these IT applications have been enabled primarily for 2 things. One, for creation of ABA ID. So all these software, they have been enabled so that ABA ID can be created. And second, whatever health record is being created, being entered into these software, they are linked to that ABA ID. Now, ABA ID creation and created that ABA ID and its linkage with the health record. So if we link that, it means that should be made available. If you go to multiple hospitals, say 10 different hospitals, and you give your ABA ID, it means health record of all these 10 hospitals, they will be available in PHR app, personal health record apps. So there are multiple apps like ABA PHR app. Arogya Setu is being converted into tracing app to basically PHR app. And Ekacare is another. I think there are multiple apps from government as well as from the private sector. So you will be able to see integrated record from different hospital wherever you go and give your ABA ID to be linked with your health record.
So got it, Sunilji, because we have shortage of time. But I think, sorry to cut you, but what he's talking about, according to me, is the portability. Remember that couple of years back, or probably a decade back, when we were having serious problems on number portability in the telecom sector. If you are having a Vodafone number, you are captive of it. You can't change the service provider because your number will change. I think this ABDM, according to me, is going to bring doctor portability and hospital portability. That's what is the accessibility part of it, because each and every policy of the healthcare in last 75 years has spoken about two aspects. One, accessibility, and second is affordability. So next question to you, Vishal, is how affordability will be taken care with the help of tech? Because this is all about tech.
So Rajiv, I think after pandemic period, the pandemic has given the answer to your question already. So we all witnessed the how tech, helped the healthcare delivery ecosystem in terms of the affordability and how it helped to bridge the gap between the traditional, healthcare delivery ecosystem. So we all know that what tech can do. There is no doubt in that. I think we all acknowledge that. There is no discussion in that. So now the other thing is what further it can do. So there are techniques which are going popular. I would just touch base because there is no elaboration required. We have limited time. So the tools like AI doctors, the tool like chatbots, the tool like telehealth, the tool like the telestock units. These are the some few advanced technologies which are really going to reduce the burden of the typical or traditional healthcare delivery ecosystem, and they are going to play a major role in terms of the reducing, or making the affordability of the healthcare. And eSanjeevani, Sunilji, I think is the best example, we can give. So eSanjeevani is the largest telehealth platform in the world, where almost 11,000 consultations are happening free of cost in the world. So that is the example, how the technology is helping in terms of the providing the traditional healthcare delivery. The second thing is, as Sushil mentioned and Sunil sir mentioned, so the initiatives like government is doing the tech initiatives in terms of the establishing a health information ecosystem, where the health records from the A provider would be available to the B provider. So if we have the adoption of the ABDM in the future, so what would happen, Rajiv, is, let's say if I'm the patient of Apollo and going to Medanta, so that there is no need to repeat my test because all my EMR, all my health records would be available to my treating or my new treating doctor. So even if I'm going Kanyakumari to Kashmir, so my health records would be available, and hence there is no need to repeat my health records. So I think these kind of initiatives, and as Sunilji, I think Sushil mentioned, the unified health interface. So that is one of the largest healthcare ecosystem which India is going to develop. So under the ABDM, so unified health interface is a network of networks. So all the players, be it the private players, the government players, the companies like Practo, 1MG, n number of whatever name you have in mind, they all would be part of that ecosystem. So right now, if I need a medicine, I am dependent. I will go Practo, or I will go, 1MG or NetMed or something like that. But if I have that ecosystem, I will just make a request, and that ecosystem will fulfill that request. So I think that we will witness those kind of initiatives soon.
I think you said it very right. We are probably, maybe next couple of years from now, when we do such similar conference, we'll talk about UPI equivalent of, healthcare. That's
I think UHI is already in place. Next time, whenever there will be workshop, we will talk of
super,
UHI.
super.
So we are already
super.
working on that, and so very soon you will, all of
Super.
you will be
Look
facilitated
forward.
on.
Look forward. Yeah, I know that pilot is on, but we know that what kind of pilots keep coming from time to time. Sushil, the gentleman is already on the verge of coming to the stage. So, okay, I know. Uh, you know, we all know that when you talk about scale, tech is the only solution, and tech is definitely going to be, after God. I think I personally believe in tech, because that's something which is totally unbiased to each and everyone. So why it is taking, why clinician thinks that tech is not the way forward? Why clinicians think that, doctors think that tech is a burden? I
Yeah,
see it on a daily basis.
Yeah, just one more example I'm giving you. We want to start the paperless hospital in AIMS. Already been in the news, already we have got the direction from a top level that AIMS is going to be paperless with the help of NIC. Yeah. Anyway, but one module we have started for the gastroenterology to make totally paperless. And we have developed such a clinical systems. It is developed by NIC also. And when we have started it, each record, if you take a new patient, it takes 35 minutes. And 35 minutes is not acceptable to the doctor. Using the 35 minutes of a doctor, entering the clinical system in the clinical information into the system, it is not acceptable. That's why doctors are hesitant because of that thing. They are killing their time to entering the data. But once the data has been entered, means next visit when patient will come, it will take very less time. But that things it is very difficult to reach. That's why the doctors are hesitant. The technology is there. Many people, they say, why not voice to the text? But in the OPD levels, the noise level is so high, that technology is not being used. So that's why the doctors are hesitant to do it. It takes a lot of time to enter the data, the clinical data. Thank you.
Thank you. And this is my last and favorite question to you, Praveen, is that we had only one Guru Dronacharya, and there, he was able to teach only 105, 100 Kauravas and 5 Pandavas. While we have many Ekallavyas, and we can't afford Ekallavyas after getting trained to donate his right hand thumb. And we have serious shortage of, healthcare workers, and we need to reskill them. What, according to you, when you talk about the scale that we are talking about in India and worldwide also, tech can play an important role?
Yeah, definitely. Like the question has an answer in itself. Tech definitely can play a vital role, and like you just mentioned, other than God, tech is the next, next best thing because it is ubiquitous, right? We can be sitting here and still be connected across the world, and I think that is the power of tech, and it has been proven time and again, and I'm sure we'll be able to utilize that, whether be it telemedicine or tele-education, where you can actually reach out to thousands and millions of attendees across the globe. So distance is not a barrier. Their language also, now you have AI-based solutions which can automatically translate the medium of education, the language. So all those barriers can be easily overcome with the help of tech. So definitely, I think that is the way to solve the problem.